So let's move on from a swollen or a pale disc to a situation where the fundus appears absolutely normal. So these are diagnostic dilemmas, because and these are you do get to see these cases fairly frequently in our practice. So it's not something that is unusual. There is a financial burden, there is a social burden. The patient goes to different places. Everybody says everything looks okay. You're saying you've got a vision loss, and so that becomes kind of like like an issue for that patient. And there are sometimes medical legal implications as well. Of course, there is a cause somewhere, and the causes could be involving any of the visual pathway, right from the macula up to the brain, the cortex. And there are some situations where we get patients who are also malingerers or having some functional vision loss as well. Occult macular dystrophies are there, situations which could be involving either the rod system or the cone system, and these are they will not find any change when you look at the fundus initially, but if you do a careful examination, you do sometimes find some changes. You can get help from tests like the multifocal ERG, though the normal pattern ERG would be normal. You could use the OCT, the ganglion cell complex scans particularly are able to pick these up. But we'll focus more on the neuro-ophthalmic conditions in this particular presentation, and we'll shift to retrobulbar neuritis, just like Professor Rohit showed a case of papillitis. So this is a situation of optic neuritis where the discs appear absolutely normal to look at. There is an RAPD in the eye that is affected. Color vision would be affected out of proportion to the vision loss that's there. There could be pain, it could be painless, and there could be associated other neurological abnormalities as well. So you need to be able to recognize RBN as a diagnosis, particularly when you're having a subacute vision loss, in the typical age group. And of course, the treatment for the you need to investigate these cases. Let's look at one case which is of RBN, which is a young female, about 32-year-old female who's presented with vision loss in the left eye, as you can see here. There is an RAPD, and that's why the pupil, you should not dilate blanketly all your cases, as Dr. Ankur in the morning pointed out. And when you look at the fundus, it appears absolutely normal. So there is no change whatsoever. Things appear absolutely normal in fundus. But when you look at the MRI, you can see that there is an involvement of the optic nerve on the left side along that tract. And so this is a case of retrobulbar neuritis and would require treatment with IVMP. Another form of optic neuropathy where the fundus may appear absolutely normal is a nutritional deficient optic neuropathy. These usually have some risk factors involved, whether it's malabsorption or alcoholism or something else that is going on. In the initial period, the discs would appear absolutely normal, though over time a disc pallor would set in. These are associated with central centrocecal scotomas, and again need to be recognized in line with the risk factors. Something which is presenting similar is the toxic optic neuropathy, and I think we have been seeing a lot of these cases in India, particularly with ethambutol being used now for the longer period. And there are implications. The methanol is implicated usually in the more in the acute phase. You would have some symptoms or signs that you can see. In the chronic phase, it would end up with a disc pallor. But more important for us is the ethambutol, amiodarone, chloramphenicol, or some of these other linozolid related optic neuropathies. Let's come to a case here. This is a young male boy who was presenting thin build, was having vision loss over time. Vision had come down to 6/12 in both the eyes, and remember, these are somewhat symmetrical vision losses that you'll get in these cases. You looked at the color vision was within normal limits initially. Contrast slightly decreased. The fundus appear absolutely normal. There was no family history of any disease. But when you look at the visual fields, you can see that there was a field defect in both the eyes, a generalized depression with a slight peripheral constriction and a central field defect. So this was a patient. When you further took history, there was no ETT usage at all, but it turned out that he was somebody who was doing an inhalation abuse, and this was an inhalant abuse associated toxic optic neuropathy. So you could have these rarer situations also that you come across. But of course, this is also the age where you want to look at Leber's hereditary optic neuropathy, and I'll come to that next, what that means, because LHON also can present in the same age group. Over time, the patient had a disc pallor that developed in, but once after he had his de-addictions center, and he was basically given some treatment by multivitamins and better nutrition, he did improve. So this is kind of one of those situations where you have to be alert to be able to catch these, because initially everything appears quite normal. Leber's hereditary optic neuropathy is something we are seeing in the adolescents age group. You could have some changes on the disc initially, like some telangiectasias, hyperemias, but these are essentially a mitochondrially inherited disease, and over time would lead to primary optic atrophies in both the eyes, which is gradually progressive. Again, needs to be recognized, and a genetic testing can pick up the mutations for you. Rarer optic neuropathies, and I see these sometimes as in the multi-speciality hospital, could be cancer-associated neuropathies. These are paraneoplastic syndromes that are happening. Also, there could be associated maculopathies, and these again need to be recognized in the line of the background of the disease that they're actually in. Posterior ischemic optic neuropathy is an ischemic optic neuropathy seen similar to the anterior ischemic optic neuropathy in terms of signs and symptoms, except that the fundus initially would appear absolutely normal, usually associated with shock or some kind of a fluid loss or a hypotension that is happening, and often would be seen after major general anesthesia surgeries that are done, particularly where there has been some sort of blood loss as well. So again, these are some things you have to be able to recognize and manage and treat early. Traumatic optic neuropathies, again, at the onset would have no change on the fundus whatsoever. If there has been a direct or an indirect trauma, there would be no change at all on the fundus, and over time, of course, a pallor may set in, but the pupils are going to give you the answer. So again, pupillary examination is very important, and this is something you can do even in a patient who's bedridden, who's in the ICU. Here we are showing a young patient who had an injury. Initially the fundus appeared normal, of course slightly pale here because this picture was taken a bit later down the line, but you could see that there was a fracture inside on the orbit, and this was a case of traumatic optic neuropathy. Needs to be treated early for the best outcome. That's there. Cortical visual impairment is something that we see in cases where in cases like HIE or ADAMS, where there has been an involvement of the cortex, of the occipital cortex, leading to vision loss. Again, the fundus would appear absolutely normal. Microtropias are small angle squints with amblyopia. Small central scotomas are there. Again, nothing would be visible. You need to also recognize malingering. So this is sometimes done with a positive, with some kind of a gain that the patient is looking for. It could be positive or negative. You have to be smarter than the patient to catch it up. There are plenty of tests that are described, and you need to be able to know some of these and use them and be able to catch out the patient. But differentiate this from hysterical or other forms of conversion disorders, which are actually psychiatric situations which require your support from your colleagues. Lots of neurological disorders like amaurosis, Fougax, or other cerebral causes can also cause vision loss with a very normal appearing fundus, and something that we need to be able to recognize. So remember, this is a situation where you have to have an high attention in terms of the history, in terms of the details, and in terms of examination beyond the fundus to be able to catch these situations and diagnose them. So thank you for that.